Good afternoon. Thank you for joining us. I'm Dr. Phoebe Thorpe, and on behalf of the Centers for Disease Control and Prevention, I'd like to welcome you to November's Public Health Grand Rounds. And I'd like to send a special hello to the Public Health Associates that are joining us. It's the largest class of the Public Health Associates that we've had so far. Continuing education credits for Public Health Grand Rounds are available for physicians, nurses, pharmacists, health educators, and others. Please see more at the Public Health Grand Rounds website, which is cdc.gov/CDC Grand Rounds. Grand Rounds is also available on all your favorite social media sites, and we have a featured video segment on YouTube called Beyond the Data, which is posted shortly after the session. We are also tweeting today, so please use hashtag CDC Grand Rounds for all your tweeting needs. In addition to today's outstanding featured speakers, whom I'd like to thank for their important and ongoing work, I'd also like to acknowledge the important contributions of the individuals listed here. And because Mr. Robert Walsh is visiting from HRSA, I'd like to point out that open enrollment for health insurance is ongoing through February 15th. We have partnered with the CDC Public Health Library and Information Center to feature scientific articles relevant to this session. Please see the full listing at cdc.gov/scienceclips. Here is a preview of upcoming Grand Round session. Please join us live or on the web for your convenience. And now I'd like to introduce CDC's Principal Deputy Director, Dr. Ileana Arias.
Good afternoon and welcome to today's Grand Rounds. Organ transplants save lives, but unfortunately there aren't enough organs for everyone who needs them. In the past 5 years, over 140,000 Americans have received an organ transplant, but at this moment, over 120,000 are waiting for an organ transplant. And last year, over 10,000 Americans died waiting for an organ, or actually became too sick to transplant while they were waiting. Lives can be saved, and lives have been saved, so we need to support organ transplantation and make sure transplantation is done safely. Required donor screening tests aim to reduce the risk of transmission of disease from organ donors to recipients. And early recognition of transplant-associated infections can lead to treatment or prevention of infection in recipients. But these screening tests are not all-inclusive. Donor risk and behavior history provides clues to what additional screening tests might be needed. But again, risk and behavior history is not always accurate or complete. Consequently, infections could be transmitted during transplantation. The Organ Procurement and Transplantation Network, or OPTN, which you'll hear about more today, has mechanisms in place to receive and investigate reports of possible infections resulting from organ transplant, that is, what we might have missed by screening tests or histories. However, some transplant-associated infections are rare, affecting less than 1% of recipients, and therefore require a very high index of suspicion. To detect and diagnose them requires someone actually looking for something unusual or unexpected. Often, recognizing these unusual donor infections comes from close collaboration and investigation by multiple clinical and public health partners. Prior collaborations, including the OPTN Disease Transmission Advisory Committee, public health and clinical care experts, and CDC pathologists, have identified, investigated, and diagnosed some unusual transplant-associated infections, which actually in turn have led to several changes that have made transplants safer. Through these investigations, additional steps have also been identified that could be implemented to further improve the safety of organ transplants. For example, instituting better communication between organ procurement centers to raise early warnings of similar but unusual symptoms might make detecting an unusual infection in multiple recipients much easier. A national active surveillance mechanism might also lead to earlier detection of symptoms and signs, and making diagnostic specimens, including autopsy specimens, available for subsequent testing so these unusual infections can be confirmed in donors and the appropriate treatment or prophylaxis offered to recipients. It's important to use every organ donated to save a life whenever possible. It's also important to identify infectious agents early, so when an infection is transmitted, organ recipients can be treated or offered prophylactic measures. CDC continues to work with its partners in the organ transplantation community to improve the safety of organ transplants and further reduce the risk of all transplant-transmitted infections, including these unusual ones. Thank you very much for joining us today, and we are all looking forward to the presentations and learning more about what's on the horizon in the area.
Thank you, Dr. Arias. And now I'm pleased to introduce Robert Walsh.
Thanks, Phoebe. And good afternoon. I'm Bob Walsh, the director of the HRSA Division of Transplantation. In 2013, 28,955 organ transplants were performed in this country. Of these, 22,967 were performed using organs procured from 268 deceased donors. As impressive as these numbers seem, the demand is even greater, with 123,913 currently waiting organ transplantation. And as you can see, the gap is increasing. Due to this disparity, approximately 18 of those waiting for a transplant die each day. In 1984, in an effort to address the national need for solid organ transplantation and to facilitate allocation and nationwide distribution of organs, Congress passed the National Organ Transplant Act, which, among other things, established the Organ Procurement and Transplantation Network, which is operated by the United Network for Organ Sharing, under contract with HRSA. It was established as a public-private partnership that brings together transplant surgeons, physicians, organ procurement specialists, and other public health representatives to, among other responsibilities, maintain the national waiting list for transplant candidates, set policy for organ transplantation, and determine whether hospitals that wish to provide organ transplant services meet the minimum requirements for designation as a transplant hospital. The OPTN membership includes all U.S. organ transplant hospitals and all U.S. organ procurement organizations. It is important to note that the OPTN's purview is limited to solid organs and does not extend to tissues or other medical products of human origin. NOTA also created this current structure for organ procurement organizations. There are now 58 OPOs certified by the Centers for Medicare and Medicaid Services that provide for deceased donor organ procurement across this country. HRSA provides oversight of the OPTN and ensures that the OPTN activity is consistent with the requirements of the National Organ Transplant Act, as well as our regulation, which is commonly referred to as the OPTN Final Rule. The OPTN Final Rule became effective in March of 2000 and established the structure, membership, and functions of the OPTN by providing high-level requirements for the OPTN policy development process, including goals for equitable allocation of organs from deceased organ donors, requirements for the OPTN waitlist, how donors and transplant candidate matches are conducted, and the subject of today's presentation, requirements that OPTN members conduct appropriate tests for potential organ donors to determine whether any contraindications exist to donor acceptance. The only absolute prohibition for organ donation was a statutory prohibition on procurement of organs from donors who were known to be infected with HIV. But the recent passage of the HIV Organ Policy Equity Act, known as the HOPE Act, that prohibition has been removed, and HRSA is working with the National Institutes of Health to develop research criteria for safe use of organs from HIV-positive donors for transplanting to patients who are already infected with HIV. It is expected that these criteria will be in place by the end of 2015. While there are no absolute prohibitions to organ donation, there are, as I mentioned, OPTN policies for required organ donor screening, and the OPTN has a mechanism in place to receive reports of expected disease transmissions resulting from organ transplant, which are reviewed by the OPTN Disease Transmission Advisory Committee, known as the DTAC, in collaboration with CDC representatives. Excuse me. Attempts to reduce the risk of transmission of disease from organ donor to recipient rely on laboratory testing of potential donors, a risk assessment interview, and required reporting of suspected donor-derived infection. The OPTN sets policy defining minimum requirements for laboratory screening of both living and deceased organ donors. With deceased organ donors, time and other practical considerations limit the testing that can reasonably be performed. Currently, required deceased donor testing includes serological testing for HIV, hepatitis B and hepatitis C, syphilis testing, as well as blood and urine cultures. EBV and CMV serologic testing results are used to determine if prophylactic strategies are required to reduce the impact of these known causes of donor-derived infection. NAT testing is now required in certain circumstances and detects viral DNA. Thus, NAT testing detects very recent infection prior to the development of antibody. In addition to laboratory testing, all potential deceased donors must undergo a medical risk assessment to screen for potential exposures to infectious agents. For deceased donors, this assessment is based on a review of medical records combined with the interviews of available friends and family of the potential donor. As many of the questions are personal, complete information may be very difficult to obtain. Screening questions may address sexual exposures, drug use, and hemodialysis to look for newly acquired hepatitis B or hepatitis C or HIV infection. These questions also address geography-specific issues to look for increased risk of tuberculosis, HTLV, and some parasites. Medical history may reveal particular risks for harboring an infection or malignancy that could be transmitted to a recipient. Recent animal exposures may suggest increased risk for some pathogens. The exact language used to ask the question may be critical. In a recent case of raccoon rabies, the potential donor's family was asked if there was any recent exposure to animals that might have rabies, and the response was no. Perhaps if the question had been asked about exposure to specific animals, including raccoons, as there was heavy raccoon exposure, including multiple bites and raccoons kept in the house, the diagnosis of rabies would have been apparent prior to organ donation. Dr. Call will provide more information on the factors considered when evaluating any, just a couple more slides, sorry. He's anxious to get up here. When he does, he will provide more information on the factors considered when evaluating any organ offer, as well as some details on the OPTN processes in place for monitoring potential disease transmissions. But before I turn the presentation over to him, I want to provide a little bit more context on the supply and demand issues that underlies organ transplant decision-making. The more than 123,000 people currently waiting for an organ transplant include people of all ages, including nearly 1,900 children. The vast majority of those waiting for a transplant need a kidney or a liver, with almost 16,000 people in need of a liver and more than 100,000 waiting a kidney transplant. In 2013, nearly 29,000 of those waiting received a transplant using organs procured from both deceased and living donors, including nearly 17,000 kidney transplants and nearly 6,500 liver transplants. Although wait times vary significantly based on the candidate's severity of illness and other factors, the median national waiting time for kidneys is nearly 4 years and nearly 1.5 years for a liver transplant. As a result, as was mentioned earlier, 6,324 transplant candidates died waiting in 2013, and an additional 4,915 became too sick to transplant. For example, they may have developed other comorbidities while waiting and became too sick, and the risk increased too much for them to believe that they would survive the transplant procedure. With this context, it is my pleasure to introduce Dr. Call, yes, who is the current chair of the OPTN Disease Transmission Advisory Committee. Thank you.
Thanks, Bob. In addition to the required donor screening test described by Bob, some centers screen for geographically or seasonally restricted pathogens that have caused serious or even fatal cases of donor-derived infection. For example, Blood products are screened for West Nile virus and Chagas disease, and FDA-approved donor screening assays are available. Due to a number of cases of donor-derived coccidiomycosis, many OPOs in the Southwest now screen for it. While results for deceased donors may not be available until after transplantation, prophylaxis may be given, and in this circumstance, outcomes have generally been good. Strongyloides, which can be fatal in immunosuppressed patients, can be easily preemptively treated in recipients of seropositive donors or in seropositive recipients. HTLV1 is extremely rare in the United States, and routine screening is not appropriate, but serologic screening of immigrants from high-risk regions is reasonable. Transplant centers have very little time to integrate a lot of information in determining if the need for transplant for a particular recipient is outweighed by the possible risk of infection in the donor. This determination requires an assessment both of donor risk and the urgency of the need for transplant for the listed recipient. For example, given the availability of hemodialysis, kidney transplantation is rarely urgent. In contrast, some patients with end-stage liver disease may have very poor survival. As is demonstrated on this graph, patients with high MELD scores indicating more severe liver disease may have only weeks or months to live, and a particular organ offer may be their best chance, even if that organ has an increased risk of transmitting an infection. In assessing the risk of a donor transmitting infection, it is critical to recognize that in certain circumstances, donor infection can be managed, and there is considerable experience preventing the transmission of infection to the recipient. For example, a donor with treated pneumococcal meningitis can be used as long as the recipient receives prophylactic antibiotics. In contrast, a donor with encephalitis of unknown etiology prevents a significant risk of transmitting potentially untreatable infection, for example, arboviral encephalitis, rabies, amoebic encephalitis, and should be used with great caution. In addition, donors with multi-drug resistant organisms, for example, donors with open abdomens after trauma, heavily treated with antibiotics with possible contamination of the organ, may transmit an infection that cannot be easily managed in the immunosuppressed recipient. Finally, donors who die from sepsis may have disseminated infection that can be transmitted to the recipient, as well as damage to organs that may limit the viability of those organs. To illustrate these points, let me describe a potential donor I was asked to evaluate regarding the risk of transmitting infection to the recipient. The donor was a young man with a history of injection drug use who was admitted to the hospital with methicillin-resistant Staph aureus infection, which included septic emboli to the brain and presumed endocarditis. Here you can see gross pictures and histological sections of mitral valve endocarditis with septic emboli to the brain. By the time of organ offer, he was afebrile and had received greater than 48 hours of antibiotic therapy. The potential recipient at my center was critically ill with end-stage pulmonary fibrosis, was mechanically ventilated in an intensive care unit. The question we faced was, should any organs from this unquestionably infected donor be used? In part, as the experience with donors with bacteremia that had received antibiotics was generally favorable, if the recipients were treated with a course of antibiotics, combined with the fact that the donor lung was of high quality and that the recipient may not live long enough to receive another offer, we elected to use these organs. However, there is virtually no published experience using donors with high-grade MRSA bacteremia. Despite the prophylactic antibiotics, 2 of the recipients, including my recipient, developed recurrent infection with MRSA. Both recipients, however, are now doing well, and I have discussed this at length with the lung recipient, whose family did sign informed consent to the increased risk associated with this donor, and they would gladly accept this organ offer again. Of note, this case of donor-derived infection was proven here at the CDC using whole genome sequencing. I would add that based on this experience, I personally would only recommend using a donor with high-grade MRSA endocarditis for a recipient unlikely to receive another organ offer. After transplantation, early recognition of donor-derived disease can be life-saving. However, currently, the only circumstance that requires follow-up is in recipients of increased risk donors for recent infection with HIV, hepatitis B, or hepatitis C. The Public Health Service has made recommendations regarding post-transplant testing for HIV and viral hepatitis for those recipients. Recognition of donor disease in all other cases relies on a high index of suspicion among clinicians caring for recipients in the post-transplant setting. If donor-derived disease is not considered, the cause of a patient's symptoms may not even enter the differential diagnosis. If the exposure occurred in the donor rather than the recipient, for example, Chagas disease would not be considered in a recipient with myocarditis who was born in the United States and never traveled to areas endemic for Chagas disease. However, if it is recognized that the donor was an immigrant from South America, the diagnosis would likely be made. One reason it is so important to recognize donor-derived infection early is that other recipients of the same donor are at risk for developing the same infection. Over the past decade, new policy was put in place to help clinicians recognize donor-derived disease and to improve communication of any donor laboratory or pathology results that might impact recipient health when these results are learned post-transplantation. Organ procurement organizations are required to report this information to all transplant centers that accepted an organ from that donor. And if there is concern that donor-derived disease could occur, this must be reported to the OPTN. In addition, transplant centers must report to the OPTN if they suspect donor-derived disease in a recipient. This allows transplant centers caring for recipients of other organs from the same donor to be notified. When suspected cases of donor-derived infection are reported to the OPTN, an OPTN committee, the Disease Transmission Advisory Committee, or DTAC, reviews these cases. The committee evaluates whether there might be a potential donor-derived infection and uses that information to educate the transplant community and improve the safety of transplantation. Membership of the DTAC includes representatives from CDC and FDA, HRSA, as well as volunteers who work in transplant ID, transplant surgery, organ procurement, and donor laboratory testing. Unexpected donor-derived infection remains extremely rare. While the numbers in the chart are obtained from a required but passive reporting system and likely underestimate the true incidence of donor-derived infection, from 2008 to 2012, 71,501 donors provided organs for 141,679 recipients. 146 donors transmitted unexpected disease to 181 recipients with 40 deaths. Thus, 0.13% of recipients had an unexpected disease transmission, and 0.03% died from such transmission. During the same period, 33,407 individuals died while on the wait list for an organ. Thus, while patient safety is a critical concern, many in the transplant community focus on increasing the available supply of organs and view with concern interventions such as required additional testing for rare transmissible disease that might, due to false positives and other process concerns, reduce the number of available organs. A breakdown of reports to the DTAC revealed that viral infections are most commonly reported and account for the largest proportion of deaths occurring as a result of donor-derived infection. High-profile cases of transmission of viral agents have included West Nile virus, lymphocytic choriomeningitis virus, and rabies virus. Virtually all bacterial infections are recognized in the first month after transplant, with infection of the anastomotic site and subsequent potentially catastrophic bleeding a potential result. Endemic fungi, particularly coccidiomycosis, has been a prominent issue among fungal infections. High-profile parasitic infections have included amoeba such as Balamuthia, as well as Chagas disease and strongyloides. The CDC reviews all cases of suspected donor-derived disease and further reviews those that include nationally notifiable diseases or are of particular public health concern. In 2013, the CDC reviewed 31 of 284, or 11% of all reported cases. The DTAC reporting system for suspected donor-derived infection is passive but required, and the variability of reporting across donor service areas demonstrates that we need to work to continue to educate the transplant community regarding when a suspected donor-derived disease needs to be reported. Each hatch mark on the x-axis represents a single organ procurement organization, and as you can see, some OPOs report many more cases than others, likely related to confusion regarding reporting requirements and perhaps undue fears about the consequence of exercising some judgment in what should be reported. Across the U.S., the total reporting rate is 2.49% of all donors, and this includes both reports by the Organ Procurement Organization of information that could lead to donor-derived disease learned post-transplant, and transplant center reports when there is concern that an unexpected donor-derived disease has occurred. Part of the DTAC's mission is to promote patient safety in the area of disease transmission. Examples of DTAC activities include an analysis that led to the discontinuation of the need for mandatory universal HTLV screening, a practice that resulted in hundreds of organs wasted due to false positive tests or HTLV-2 infection. We created formal guidelines regarding risk assessment for tuberculosis in living donors and for geographic or seasonally limited diseases, as well as a guidance document to help inform clinicians on considerations guiding the use of donors with possible CNS infections of unknown etiology. We recently provided the transplant community with information to help them evaluate donors for potential infection with Ebola virus. One of our current projects involves improving the process whereby information learned post-transplant, for example, donor cultures or autopsy results, are effectively communicated to transplant centers, as failures in the process have resulted in donor-derived infections in the past. I will now turn the presentation over to Dr. Zaki.
Thanks, Dan, and good afternoon. I'd like to share with you some of the unexpected and novel donor-derived infections that we have identified here at CDC over the past 12 years. These present multiple challenges, including not being screened for in the donor, unknown incidents associated with significant morbidity and mortality, and obviously with high-profile events, as you can see from this slide here, with some of the headlines associated with transplant of rabies, LCMV, West Nile, and amoebic infections. This is a list of some of the agents that we have identified over the past 12 years, and the number below them is the number of clusters that we have since recognized since the original recognition of this association. I'd like to first share you with briefly the story of events that occurred back in 2002. It started by a young female who was involved in a car accident, which made it necessary for her to get multiple transfusions. Unfortunately, she died. She donated all her organs and all the recipients came down with a febrile illness. One of these patients succumbed to his disease actually next door here at Emory, and was thought to actually be due to West Nile. However, his serology was negative. So we did the autopsy and actually saw severe encephalitis. You can see here the perivascular cuffing, and it actually turns out it was due to West Nile virus, and you can see the viral antigens in red in the CNS of this patient. This stimulated a traceback investigation and led to identifying, this recipient had received about 60 components from 63 donors, and led to identification of 2 components that have evidence of West Nile. Diagnosing this infection led, to different thinking about our West Nile and blood transfusion and solid organ transplants. This event occurred back in 2003. The story starts when a male died of head trauma. He donated his organs, and 4 recipients, all of whom died. At that point, we received the cases for evaluation. The common feature in all of these patients, as you can see here, was the massive hepatocellular necrosis. The usual things that you think about in such cases are things like herpes or adenovirus, which we screened for and were negative. So we were kind of at a dead end until a culture and EM identified a virus, LCMV, or lymphocytic choriomeningitis virus, and then subsequently by PCR, and we went back to the tissues, and all of them were positive for LCMV in all recipients. We thought this would be an isolated event, a very rare one, and we would never see it again. But we were wrong. 2 years later, in 2005, we investigated another cluster in Rhode Island with 3 transplant recipients from a single donor. This time, we also saw massive hepatocellular necrosis, and because of our earlier experience, we quickly diagnosed this as being due to LCMV by using IHC and PCR. This also led back to a traceback investigation, and it turns out that the donor's daughter had a pet hamster hammy. Actually, she had several hammies. Every time one would die, her mom would replace it with another pet hamster. As a good mother, she took care of cleaning the cages and the area of the hamster's activity, and she got enough virus in her system not to cause her clinical illness. She died of a cerebrovascular accident, but had enough virus in her system to transmit then to the donors. As you can see from this slide, the sequence from all the recipients, the hamsters, the pet store hamsters, all were identical. They were different from the 2003 cluster. So this provided a definite link to this animal or zoonotic source. This is just the scene of my colleague Brian Aman at that facility, the rodent distributor, and he's chasing a mouse that got loose in among these cages. Obviously a good way to transmit infection among these rodents, and this actually facility had a very high rate of infection with LCMV. Just want to point out that if you focus on the area in red, that we tested the donor using different assays, immunohistochemistry, PCR, serology, and culture. Everything was negative. So this is not a good infection to actually be screening for. The better way of screening, as Dr. Walsh pointed out, is asking the right question, asking about the specific exposure to link it to the transplant. Finally, this was the third cluster, and this cluster was actually identified by a total different way, by molecular diagnostics, a technique called massive parallel sequencing, which is a shotgun approach, very high throughput, and it again identified LCMV. So I just wanted to show you 3 examples of 3 different clusters. One was diagnosed by cell culture, the second by immunohistochemistry, and the third by advanced molecular diagnostics. Obviously, advanced molecular diagnostics is a rapidly changing field, and I expect in the next years that this will be one of the primary tools to diagnose these infections. We were contacted by a pathologist in Texas in 2004 about this cluster. There were 2 unexplained deaths and a third patient with altered mental status. And actually, the connection of a common donor was recognized by the patient's families who were in an intensive care unit. The donor was a 20-year-old black male. He was admitted and discharged from 2 hospitals on the same day, complaining of the symptoms that were attributed to a mild urinary tract infections. His condition deteriorated, and he was declared dead. And actually, you can see from the chart here his complaints. I draw your attention. I can't even swallow my own spit. Eventually, all 4 recipients died within 2 months. We got the tissue to examine, and when we looked at them, this is a section on the upper left hand from the brain, and you can see those reddish inclusions in the brain. These are Negri bodies characteristic of rabies, and you can see an inflamed nerve on the lower left. And on the right, you can see the immunohistochemical staining confirming the virus in these tissues. Now, during the investigation, we got another call from the same pathologist. She found out that there was a fourth death due to encephalitis in a renal transplant recipient, a liver transplant recipient. She thought it was due to encephalitis due to West Nile virus. We got the tissues, and the important thing that the donor was different from the previous donor. So when we looked at it again, you can see the negri bodies. Turns out again it was rabies. It was a big surprise. We didn't expect that. And this really threw us for a loop. Obviously, this raised many questions, such as, was there a link between the first three cases and this case? Was the recipient infection unrelated to transplant? Was the second donor infected? Was this healthcare worker transmission of rabies? This slide shows you the liver from the second donor. But actually what the surgeons did to transplant the liver was to use a graft, an arterial stump that you can see here surrounded in red. So that stump was from the original donor. So it was actually made the link that it was actually the same donor. Obviously that was a big relief to find that. As a result of this investigation, better regulations for tracking of organs and tissues were subsequently instituted. So eventually this rabies was confirmed as a bat rabies, the most common type of rabies in the US. The donor serum was positive, and the sequence from all three recipients were exactly the same. This is another cluster of rabies transmission from a single donor. The kidney transplant recipient died 18 months post-transplant. The donor had a history of raccoon exposure, died with fever, vomiting, seizures, and dysphagia. Again, we looked at the tissues, and again, it was confirmed that it was rabies. In this case, it was raccoon variant rabies. And the good news was that 3 other organ recipients completed post-exposure prophylaxis and remained asymptomatic with serum rabies neutralizing antibodies. So to summarize the impact from clusters of transmitted rabies, from the bat cluster, we learned that rabies could be transmitted through organ transplantation, and that we instituted, or different federal agency instituted better tracking of the organs and tissues from the donors. From the raccoon cluster, we learned that rabies can be transmitted from raccoons, may have actually a longer incubation. As you remember, it was 18 months since the patient got the transplant. And post-exposure prophylaxis was viable in these patients. During the 2009 pandemic influenza, we received a lot of specimens for testing that year. Everything was coming in for influenza testing, including this case. This was the organ donor had thought to have died of acute demyelinating encephalomyelitis following influenza A infection. The organs were transplanted, and a renal recipient fell ill. We had a chance to look at the donor autopsy tissues, and it turns out you can see the trophocytes in the middle here with the typical karyosomes to be amoebic infection, specifically Balamuthia by immunohistochemical testing. And 3 recipients recovered with therapy. This is another cluster of transplant-associated Balamuthia from a common donor. 2 recipients came down with an encephalitis. The liver recipient had these ring-enhancing lesions, and this is the tissue from the liver biopsy, I believe. These are the trophozoites again, and these are the immunohistochemical staining. Again, it turned out to be Balamuthia. This is the kidney pancreas recipient. He had the same MRI findings and the same pathology findings. The heart and kidney recipients were placed on preemptive therapy and survived. In retrospect, the donor had the similar MRI findings you can see here in the bottom, and very characteristic skin lesions on his left shoulder. Such lesions are known to precede neurologic signs of encephalitis in persons infected with Balamuthia. So it was a missed connection there. Another cluster, this occurred in 2012. The donor here was a 37-year-old woman living in El Paso. She had died of a cerebrovascular accident. She transplanted, or organs were transplanted, and the recipients came down with fever and an encephalopathy. The right kidney recipient was doing well. The outside serology on the left kidney recipient showed that there was antibodies to brucella, and that was the current thinking, and that's what the patients were being treated for. Unfortunately, the left kidney recipient's conditions deteriorated, and he had to have a nephrectomy. And you can see the sample here and the micro abscesses on the right on the surface of the kidney. On examination of the nephrectomy specimen, we didn't find brucella, but we found evidence of microsporidia by histopathology, special stains, immunohistochemistry, and EM. And by PCR, it turned out that it was E. cuniculi as the cause of this disease. So eventually, all three recipients were found to be infected by the same genotype. The right kidney recipient, who you can see his biopsy down there, recovered after 6 months of albendazole therapy. So in summary, about these unusual and novel transplant-associated infections, how unusual? They are certainly rare, but more than we expected previously. And obviously, if you learn about a problem, you can diagnose it. So since then, as I showed you earlier, there were multiple clusters of these same diseases that have been recognized since then. I want to emphasize the role of pathology as in the front line in terms of recognition of these emerging infections and guiding epidemiologic investigations. These investigations have increased clinical awareness about these novel infections and improved donor screening. Finally, I would like to stress the importance of donor autopsies and archived specimens in these investigations. I hope that in the future, donor autopsy will be mandatory on all donors. I'd like to acknowledge many people, actually too many to list. This work would not have been possible without them. And obviously you can see there's a lot of groups both within here at CDC and outside of CDC and state health departments and academic institutions. I'd like to now introduce Dr. Sridhar Basavaraju to give us the next talk. Thank you.
So good afternoon. Today I will discuss overcoming some of the challenges to preventing unusual transplant-associated infections, which have been discussed today. Between 2002 and 2012, CDC investigated several unusual transplant-transmitted infection clusters, most presenting as infectious encephalitis among recipients. There have been 6 reported clusters of West Nile virus transmission from organ donors affecting 16 recipients. Though not all recipients developed infection, 4 recipients died. 4 clusters of lymphocytic chorea meningitis virus, or LCMV, with infection in 13 recipients and 10 deaths. 2 clusters of transplant-transmitted rabies infection with 8 total recipients, 5 which experienced disease and died. Because we were able to connect the dots for this cluster, 3 recipients in one of the clusters were identified before symptom onset and given post-exposure prophylaxis and survived. There have been 2 published clusters of transplant-transmitted Balamuthia mandrillaris with 7 recipients and 3 deaths. In the Balamuthia clusters as well, preemptive therapy was given to 4 recipients once disease was identified. Collectively, 14 clusters of unusual transplant-transmitted infectious encephalitis have been reported to CDC, with 14 organ donors, 44 total recipients, though not all were infected, and 22 recipients died. Through CDC's investigation of these clusters, several common themes have emerged. First, the donor infection was not recognized before the organs were transplanted, probably for several reasons. These diseases are rare and infrequently encountered. Many of the donors did not appear to have obvious evidence of an infection at the time of death, and death was frequently attributed to another cause, such as intracranial hemorrhage. Some donors had evidence of meningoencephalitis, including an abnormal lumbar puncture, but the diagnosis was not made by the clinicians caring for the donor. Recognition of the infection in organ donors can be further complicated in some infections, for example, microsporidia, that do not have clearly identified risk factors, which could be elicited on a medical and social behavioral questionnaire administered to the next of kin. Even when risk factors are included, next of kin who complete the donor history questionnaire may be unaware of high-risk exposures or certain behaviors. With the exception of West Nile virus, there are no screening tests available for these infections. Also, just like the difficulty encountered in diagnosing these infections in donors, these infections are difficult to diagnose in recipients. Because the recipients are often spread out around the country, recognizing the symptoms that would link donor and recipient infections, that is, connecting the dots in a timely manner that would allow therapeutic or preventive intervention, has often been difficult. Finally, there is no active surveillance system, complicating prompt recognition and communication of findings. There are some opportunities for prevention of transplant-transmitted infections, particularly for those presenting as infectious encephalitis. The first opportunity is to enhance national surveillance efforts through implementation of active surveillance. As Dan mentioned earlier, currently transplant-transmitted infections are reported through a passive reporting mechanism where transplant centers or organ procurement organizations report to the OPTN once a donor-derived infection is suspected. The current system likely results in under-recognition and under-reporting. Establishing an active national surveillance system could enhance the recognition of these infections. This would include reporting of denominator data, such as total transplants performed, implementation of case definition criteria, and an electronic notification system of all transplant centers once a case is suspected or identified. Another opportunity for prevention is improved screening of donors. OPOs across the country may use different donor history questionnaires to elicit behavioral and medical risk factors. Though no questionnaire can successfully screen with 100% sensitivity, standardized, validated questionnaires administered to next of kin could result in improved recognition of risk factors. But we must remember that any potential gain of identifying donors with an increased risk of infectious encephalitis must be weighed against the potential loss of organs available for transplant. Thus, the goal of any screening program is to both distinguish infectious encephalitis from non-infectious encephalitis, such as anti-NMDA encephalitis, and further optimize the organ allocation system. Recognition of infectious encephalitis in donors could be improved using a surveillance system that incorporates all of the available information. If risk of infectious encephalitis is increased, it would trigger additional laboratory testing and follow-up with recipients. Early identification would lead to potentially therapeutic or prophylactic intervention. CDC is working on a risk stratification model to improve donor screening and stratify the risk of donors with encephalitis, with the goal to both distinguish infectious encephalitis from non-infectious encephalitis and further optimize the organ allocation system. This project has 3 main objectives. First is to develop a tool for clinicians that allows them to better identify donors at high risk for infectious encephalitis. This tool must distinguish infectious and therefore transplant-transmissible from non-infectious encephalitis using available clinical data such as the presence of a fever and other symptoms, cerebrospinal fluid analysis, and imaging results. And the tools must integrate data from donor history questionnaires. The second objective is to develop a method to properly allocate organs from donors identified as increased risk for infectious encephalitis, understanding that some recipients may have a survival benefit from these organs because of their life expectancy while waiting for an organ. The third objective is to re-optimize the organ allocation algorithms. By doing so, the goal is to reduce the overall opportunity cost on the organ matching process by ensuring the best use for these increased risk organs. By reduction of opportunity cost, we mean we want to maximize the collective overall survival among recipients by appropriate allocation of organs identified as at increased risk. In other words, make use of every organ if possible. To accomplish these tasks, we've gathered a diverse group of individuals, both within and outside of CDC. To identify clinically relevant variables, CDC clinicians and epidemiologists have collected publicly available data in published literature from case reports of infectious and non-infectious encephalitis and assembled an extensive database. Our colleagues at OPTN and UNOS have provided data on patient characteristics of individuals waiting for organs. To optimize this process, we're working with a student team in the Industrial and Systems Engineering Department at Georgia Tech to analyze these data using techniques geared towards solving efficiency problems to develop a donor risk index classification and computing a tipping point to maximize recipient survival benefit. In conclusion, I would like to emphasize that the risk for any unexpected donor-derived infectious disease transmission is low, and even lower for an unusual pathogen described today. Not all of these infections can be entirely prevented. However, many individuals die before an organ becomes available for transplant. As a result, for most candidates, the benefits of organ transplantation outweigh the risks. Using as much relevant data as possible to inform risk assessment could improve outcomes. CDC continues to work with partners in the organ transplantation community to further reduce the risk of unusual transplant-transmitted infections.
Keep the questions short since we're running out of time. Susan?
We have questions from our online audience. How do you assess when the risk of infection is too great and outweighs the benefits to the patient?
So you have to take a whole number of factors into consideration that are specific to that particular recipient and how much that recipient needs that particular organ. So, for instance, if it is someone who has very late stage liver disease, they may have that may be the only organ offer that they're going to get, and so you might accept an organ that's of higher risk of infection. And we try and resolve most of these conflicts by using or balance these by using informed consent and discussing with the potential recipient or their family the particular characteristics of that donor that increases the risk and what the consequences of transmission might be to involve them in the decision-making process.
Please go ahead.
I'm sorry. I can touch on that briefly. This presentation focused solely on solid organ transplantation. Bone marrow definitely has different issues. The infection screening is treated differently. As was stated early in the presentation here, one of the challenges that is specific with deceased donor solid organ transplantation is that there's not the luxury of time often to do all of the screening that one might want to do to rule out as much of the risk as possible, given the limited amount of time that you can maintain the donor and the organs are viable outside of the body. But on the bone marrow side, screening is significantly different than occurs on the solid organ side.
Bone marrow donors are also living, so the history can be more reliably ascertained also than it could be from deceased donors and organs.
Susan?
As a neglected tropical disease rapidly encroaching on the United States, are organ donors always being tested for Chagas disease?
No, it's not required to test for Chagas disease for organ donors. There are some organ procurement organizations or living donor centers in particular. So, for example, in Miami, to my knowledge, they will test for Chagas disease in at-risk donors. But I would say most deceased donors are not being tested for Chagas disease.
So, go ahead, Susan.
Again, from our online audiences. Has any veteran or family member who served in Europe ever developed mad cow-related neurological symptoms? The question is relating to someone who served in England and used to be a blood donor, and then when the new rules came in that they could not donate. So his question relates to where are we on that? Has anybody ever developed symptoms?
I'm not certain. I don't have the entire set of data in front of me. And blood screening procedures are different than solid organ screening. I'm sorry, I just don't have the information to be able to adequately answer the question.
But just to clarify, it has been transmitted by blood transfusions in general.
Thank you all for joining us, and thank you, and join us next month. Bye.